Today, we are demystifying Mobitz 1. We're going to understand it so deeply so that you never have to worry about it anymore. Hello and welcome to the YouTube channel. On this channel, we break down ECGs so that they are stupid simple. If you're new here, please let us know what part of the videos you found helpful. Share, subscribe, like, and yes, here we go. Now, Mobitz 1 is a type of second-degree heart block, so that means you should have known about the first-degree heart block. And we have another video on that explains first-degree heart block, so we will not take too much time on first-degree heart block. There are two types of second-degree heart blocks, Mobitz Type 1 and Mobitz Type 2. And they are really different because the way you would manage them would be completely different. While Mobitz Type 1 is very not dangerous, 90% of the times not dangerous, Mobitz Type 2 needs to be taken more seriously because the block, the so-called block, or better still the delay, is happening at a level below the atrioventricular node. Now, there's another video that talks about the conduction system of the heart, and it talks about where the impulses are being produced, the sinoatrial node, how they travel down to the atrioventricular node, and when it becomes dangerous or not. But let's stick to type 1 second degree heart block called Mobitz Type 1. Another name for it is called the Wenckebach. Let's make this more practical, should we? Now look at this ECG. I have printed out a rhythm strip for this ECG. The rhythm strip is usually the longest rhythm. It starts from the beginning of your strip to the end of your strip. And for most people, it's often on a 25 millimeter per second paper. Now, the first clue to you recognizing that this is a second degree Mobitz 1 or Wenckebach is that you find clusters. Now, this ECG seems to be having clusters of complexes, the PQRS complexes. And this tells me that it's either one of three things going on in this ECG. It's either there's a Wenckebach, it's either there's a premature atrial complex, or there is a sinoatrial exit block. But I will be able to easily pick out that this is a Wenckebach by just focusing in on a few things, which I want to show you today. And guaranteed that you will never miss any Wenckebach after you see what I'm about to show you. So the first clue is to identify your P wave. We know that a P wave is the first positive deflection. So this picks out that this is your P wave, and this picks out that this is another P wave because it's occurring as the first positive deflection before your QRS. Now that's the basics. Again, watch the video on basics if you find any part of the P wave QRS complex confusing. Now, what I need to identify is what is the pattern here? Even though they are in clusters, what is the relationship between my P wave and my R wave? Now, if you didn't know as well, the R wave is the next positive sharp upward deflection you will find after a P wave. So this makes this our R wave, and this makes this our R wave. So in Wenckebach, the key thing is that there's a progressive PR prolongation until you have a P wave that is too stretched, it is not resulting in a QRS interval anymore. So this makes, understanding the pattern will help you know whether there is indeed a pattern or whether this is just occurring haphazardly. Now I'm going to use my ECG ruler here. Some people use ECG rulers, some use calipers, and some just count the small squares to calculate their PR interval. And you should already know that your PR interval should not be more than 5 small boxes. Whenever you see a PR interval that is more than 5 small boxes, that's a giveaway for you. It is a block going on there. So, and then the next thing would be to find out what block it is. Moving on from that, I'm just going to try and calculate my PR interval using this ruler. Now, when I check the first complex I have here, I find out that my PR interval is about 6 small boxes. There's a block. And I go on to the second P wave, and what do I see here? It's about 7 small boxes now, right? Now that is 5 and then 7. And then when I move on here, it's about 10. 5, 7, 10. There is a pattern here. It's getting stretched and stretched. Then I look for my next P wave. My next P wave is occurring so close to my T. Now, if you didn't know, the next upward deflection or the next curve after your QRS is the T. So immediately after my T, there is a P wave going on here. And this P wave as well, this P wave is coming immediately after my T, and then the P wave is not conducting into any QRS. So the P wave is prolonged here, it's prolonged here, it's stretched even further here, right? Until you have one that is so stretched, and as at here you're having about 12 boxes, one that is so stretched that it is not even conducting into a QRS interval. So the trick here is, first, are my P waves, is there a cluster? Second, is my PR interval being progressively prolonged? Thirdly, is there a P wave eventually at the end of that prolongation that is not being conducted into a QRS? If that is the case, that is your giveaway. It is a Wenckebach. And as you can see, it kind of resets, because when you see this P wave that does not conduct into a QRS interval here, there is a pause before another P wave. There is a missing QRS. Now, another trick for those who just want one more thing under their belt is that you will find that the P interval, the PP interval, right? This is a P. The PP interval is the same. So in Wenckebach, your PP interval is always regular, but your RR interval is not regular. And that helps you. Now, let's break this down a bit more clearly. If you have a non-conducted premature atrial complex, it may look like this, but you will not find this P wave that is not being conducted. In a pack, you will have it being grouped together, but this P wave, it will be absent. And then you will also have the PQRS complex looking quite different. Also, here in a Mobitz Type 1, you will find that the compensatory, this pause, which we'll call the compensatory pause in other ECGs, is not compensatory. And let me explain that. A pause is usually compensatory when you find out that you can fit any of these other QRS complex in this interval. Now, if an entire P wave is missing and the pulse equals an entire QRS interval, PQRS interval, then that is not a Wenckebach. That is usually either a PAC, that's your premature atrial complexes, or something else. In Wenckebach, the P wave is present but not conducted, while in sinoatrial node exit block, the P wave never occurs. In PAC, the P waves will also not occur, and that distinction is gold. Now let's look into practical examples here. So now, and this is something I also wanted to flag up. We could use this first one. What you will find here as well is that you can count in each cluster. What is how many QRSs do you have? 1, 2, 3, 4, 5. So you have 5 halves, but how many P waves do you have? You have 1, 2, 3, 4, 5, 6. And some will call this a 5-to-6 ratio. So using a practical example here, another practical example here, what you will find as well is everything we've said. There is a cluster, there's a prolongation of the PR interval, there's a P wave here that does not get conducted into a QRS. And the pause is not compensatory. You cannot fit a QRS into this particular pause that you have here. And when you count the R intervals, the QRS or the R intervals or the R waves, what you have here is 1, 2, 3, and 4. But when you count the P waves, you have 1, 2, 3, 4, and 5. And so some will say there's a 5-to-4 ratio going on here. Now, the ratio at the basic level is not very important because it really doesn't change how you treat a Wenckebach. A Wenckebach, like I said, might just be due to the fact that your patient is on digoxin. It might be due to the fact that they are athletes professionally performing and their heart has learned to adapt in such a way. It could also be due to the fact that they're on calcium channel blockers. But if, on the other hand, they're having some chest pain, they are elderly, they have risk factors like hypertension, diabetes, and the way they're describing their chest pain is very cardiac, I would look into it because many times you could have an inferior myocardial infarction also presenting with a Wenckebach block. What I would need you to understand here is if the PR is getting longer before it drops, it's Wenckebach. If it drops without warning, think Mobitz Type 2, right? But if you're getting that warning and saying, oh, I'm getting stretched, like I can stretch no more, and there's a P wave and the QRS is missing, go pick the right answer, Wenckebach, and then assess the patient, put it into clinical context. Ask yourself, what is my patient doing? Are they here because we wanted to do an ECG routinely? Or are they here because they're unwell, chest pain, cold, and clammy? In that case, I would escalate. Otherwise, I might just send cardiology a routine opinion form for the patient to get followed up, or, just monitor the patient and have serial ECGs to make sure that there are no problems. If you enjoyed this, let me know in the comments below.